were aware that people with Alzheimer's and other dementias didn't have a diagnosis in their hospital record, and probably the conditions weren't being recognized. And we wanted to create a tool that would suggest ways that different hospitals might choose to try to increase the recognition of dementia.
I'm going to ask you a few questions. That's okay with you?
It's okay.
I'm here with a student who's working with me. Her name is Carrie. I just want to make sure that I'm talking to the right person. Miss Claire Trader. Can you tell me your birthday, please?
August 27th, 1920.
Thank you.
Mrs. Trader, age 83, is being admitted to the hospital for a total knee replacement. As part of the screening process to detect dementia, the staff nurse will be using the Recognizing Dementia tool to ask questions about the patient's daily activities. Does the patient repeat or ask the same thing over and over? Does the patient forget appointments and family events? Handle her or his own personal finances? Shop independently? Take medications according to instructions? Get lost while walking or driving? Have difficulty with making decisions related to everyday living? The tool also helps the nurse watch for behavioral triggers that may indicate a dementia. Does the patient seem disoriented? Is the patient a poor historian regarding his or her own medical history? Does the patient defer to family members to answer questions? Have trouble following directions? Have difficulty finding the right words? Have difficulty following conversations?
How old are you?
83.
83. Okay. And what are your living situations? Are you living with your family?
I'm living with my daughter and her husband.
In terms of at the house, are you able to feed yourself?
Yes,
And with who does the cooking in the house?
my daughter and her husband.
Bathing, do you need help with bathing?
I can bathe, but she always stands by to help me get out of the shower.
Okay. And going to the bathroom, are you able to go to the bathroom okay?
Yes,
Okay. And you can hold your bowels too?
yes.
What about meals?
They fix the meals
They
for
fix
me.
the meals for you. Okay. And your medication, do you?
They have it fixed, and sometimes I go and take it. They always have it sitting there ready for me.
Okay. And the finances, who takes care of that?
My daughter.
Your husband. Are you still driving at this point?
No.
They do the driving for you. What about going grocery shopping?
They do that.
They do that. Okay.
I follow along with them every once in a while,
Okay.
if they'll push me.
Can you tell me what the date is today?
The 9th,
And the month?
October.
October. Can you tell me the year?
The year is 2007.
2007, thank you. Do you know where we are right now?
We in the hospital.
The hospital, the North Memorial Hospital. Okay. And I saw when you came in, you were in a wheelchair. Do you use a wheelchair all the time?
If I go somewhere in a distance, like grocery shopping or
Walks.
she takes me for a walk.
Yeah. But if it was short distance, you're able to do that without any...
Short distance, very short, yeah.
You can do that, okay. Do you need glasses?
Yes,
You need glasses. What about hearing?
I can hear good.
She hears everything.
Everything.
Yes.
You gotta be careful, huh? And in the last 3 months, have you been in the emergency room at all?
No,
And in terms of diagnosis, how many different diagnoses do you have?
I have, how many do I have?
COPD emphysema. She was diagnosed with diabetes, but since she's moved to Minnesota, that's good. Congestive heart failure.
And do you guys have any concerns in terms of memory loss? Because this is a tool we use, to see if there's any memory loss involved.
Yes.
Yes. Notice forgetting things?
Yes.
Okay. Thanks for answering those questions, Clara. Me and Carrie are going to go through this and look at the doctor's orders, and then we'll come back and let you know what the plan is. And,
Okay.
anything I can get for you before we leave?
No, thank
You okay? Okay.
The Alzheimer's Association estimates that there might be 500,000 people in the United States under age 65 with dementia of some kind, caused by Alzheimer's, caused by frontotemporal disease, other conditions. But the great majority of people are older people. So it's estimated that maybe 1% of Americans age 60 to 64 have dementia, 2% of Americans age 65 to 74, then going up much more rapidly to the estimate we use is 42% of people aged 85 and over. So there's a very high increase in prevalence with age. Most people who come into a hospital with dementia don't have anything in their record to show it, and so when you use the usual data sources, you can't tell how many have dementia. We've looked at everything that we can find, and we think that across the board, across hospitals, it's probably an average of about 25% of elderly hospital patients at any one time are people with cognitive impairment, dementia. That doesn't mean that that's what they came into the hospital for. Usually it isn't what they came in for. They came in for treatment of their chronic or acute medical condition, but they have a coexisting dementia. If you take the average, you think that the average across hospitals is 25% of people age 65 and over in the hospital at any one time might have Alzheimer's or another dementia, and then you look for other information to try to figure out how many of those people are detected. Is it in their record or not? I think there's a huge amount of under detection. One study that was done at Johns Hopkins Hospital looking at discharge records, and those records over a 2-year period showed that only 4% of elderly patients had anything, a diagnosis of Alzheimer's or another dementia in their record at the point of discharge. So you compare the 4%, and that's a good, very good hospital, of course, and then the 25%, and you have a huge underdetection there. We have looked at what we can find in research about what happens to people with pre-existing dementia when they come into the hospital. So the available data show a huge high risk for delirium developing, much higher than older people who don't have that pre-existing dementia. Increased risk for falls, for problems with eating, for agitation, problems with new incontinence. People who were not incontinent when they came in, people with dementia are much more likely to become incontinent than other hospital patients. These people are much more likely also to be discharged to a nursing home. That is, people who come in from home to be discharged to a nursing home, to be in that nursing home 3 months after discharge. I think it's 3 to 7 times more likely than other elderly hospital patients. And the 3 to 7 times depends on the severity of their cognitive impairment. So there are all of these risks. Another one I didn't mention, restraints. Use of restraints, use of psychotropic medications are very much higher for hospital patients with dementia than for other hospital patients. And the idea behind this detection of dementia is to let nurses and others know that this is here's a patient at high risk of these negative health outcomes, so that they can apply nursing interventions and other interventions that can avoid these problems. The benefit to the patient is huge. The benefit to the family in terms of reduced anxiety, and then being able to take care of this person that they care about longer over time. And for the hospital, I think that the people with dementia can be very difficult for hospital staff, and so avoiding those negative outcomes can be good for the staff in terms of their own quality of their work environment, but also valuable to the hospital in terms of avoiding costly negative health outcomes in the hospital, and then post-hospital readmissions and so on.
With the information we gathered, it shows that this patient is at risk for memory loss, and we're trying to get a plan, see what we can do to help her while she's here in the hospital, and hopefully the information we can share with the family to help her when she gets discharged.
Well, good. And actually, this is perfect timing because Katie Maslow is here, and she's from the Alzheimer's Association, and she's at North Memorial today to give us a consultation and help us get some insights about Alzheimer's. So tell me, was there concerns from the family's perspective about memory loss?
Well, they seem to be happy that she's pretty sharp but a little forgetful.
Okay.
But talking to her, there's a few things. She could barely remember the month of the year, and a couple times she looked to the family to help her answering questions.
So it sounds as though you did the family questionnaire, and that really was coming up as a positive that there could be some memory loss concerns. Okay.
And I was wondering too, is it uncomfortable for you to ask questions regarding memory loss to patients and their families?
Sometimes families feel uncomfortable or a little bit get upset when you're asking questions like that, but it's very important for them to know that they're helping us to help her.
Actually, in a few hospitals that have tried this kind of approach that's being used here at North Memorial, some of the response is really the families are happy that someone raised the issue. Some families aren't aware of the dementia, but families that are aware that the person has some memory loss or dementia are often worried about what's going to happen in the hospital, and do the nurses know, and do they know how to take care of this person?
There's several other clinical triggers that we should be looking for these patients that have memory loss. One is if they're really having a difficult time following directions. If we're trying to get them up to the commode and they're really having a difficult time understanding what they need to be doing, or when they're having difficulty finding words, or maybe they're actually looking to their family member to say, what's that word that I'm looking for? And then lastly, they may even have difficulty following conversation. Maybe you're doing some patient education preoperatively with this patient. You may find that you want the family members there so that they can reinforce what needs to be understood following the surgery that she's going to be having.
It would be great if this became more routine, the identification of possible dementia or memory loss. Then nursing staff can begin to prepare, I think, to avoid falls, delirium, all of the things that you've been talking about.
The importance is bringing the whole team together. It's important for them to understand the impact that the memory loss has on every nursing intervention probably that they do, whether it's patient teaching, whether it's going in and doing a procedure, whether it's getting them up and walking. All those things may need a little different tactic in order to be successful for that patient. So it's integrating those key things into the nursing care so that we can keep them safe. I mean, that's the bottom line, is safety is a huge issue for these patients when they come into the hospital setting. So now we have to put together a plan for what we might want to make sure to keep her safe while she's here. One of the things that comes to my mind is, because she has some memory loss, or we think that she has some memory loss, she won't necessarily remember the nurse, you taking care of her, and what your name might be. So every time a staff member comes into the room, you should tell the patient your name and your role also, because of the high volume of people that come in. It can be kind of a scary situation if you don't know who that person is and what they're going to be doing. The other thing is the risk for falls. She probably has some difficulty with her mobility since she's coming in for a knee replacement, and we want to try to prevent a fall. So one of the ways, because she may not remember to use the call light, we could try hourly rounding with her, which means either the nurse or the nursing assistant or the nursing student hourly go into the room, monitor her pain, help her to the bathroom, so that you decrease that risk that she's going to just get up and go to the bathroom and potentially hurt herself even prior to going to surgery, and actually post-surgery as well. One of the key other team members is occupational therapy, because there's several different tests that we might want to consider doing when she goes home through home care, one being the cognitive performance test, and that's an ability for us to have the patient or for us to understand the functional ability of this person and what deficits they might have, so that we can make that smooth transition from the hospital to their home, or whichever level of care they might need. Her history includes COPD, CHF, and hypertension. She actually has had a bad last 6 months. She had a silent MI. She's had 3 bouts of the same type of infection, pneumonia. She had a failure to thrive, malnutrition. So she's had a lot going on. She's really at risk for needing additional support at home after she has her total knee. We also did the family questionnaire. And the family questionnaire told us that the family is assisting with bills, with medications, with meals. They're doing the driving now. She no longer drives independently. So we really are thinking that this patient likely has some memory loss. And because of having that underlying memory loss, we really wanted to get the team together to try to discuss what can we do to reduce the risk that for getting delirium. And so I wanted to get this group together to get ideas generated. We did talk a little bit earlier, Makessa and I, about pain management. So I wanted to get your thoughts, Dr. Smith, on pain management for this patient.
We've talked before in this group about, what you want to do is schedule a pain medication. You don't want to wait until the person's in pain, because then it's going to take that much more pain medication to help them. The best thing to do in this scenario, because you want to minimize the risk of side effects of delirium, would be to use scheduled Tylenol. You want to maximize that. And then have a PRN medication such as oxycodone or morphine, and then use the smallest dose that will work to get them through any kind of breakthrough pain.
Okay. And what kind of side effects, are likely to occur with someone that has underlying memory loss?
Well, from the pain medication, obviously make their memory loss that much worse. Put them at risk for hallucinations or delusional thinking here in the hospital. Potentially make them lethargic and not take in fluids as well. So we want to be paying attention. Are they really eating and drinking? We want to be careful that we're not bringing a tray in and leaving it to that person and then coming back a half hour later and taking it away, and they really didn't, eat anything, drink anything. Constipation, anticipate that if we're going to give them narcotics that they might get constipated, because an impaction alone can precipitate an episode of delirium. So we want to pay attention to that. But I think one of the big things we often miss is the lethargy associated with pain medication, and then we're not paying attention, is the person adequately eating and drinking.
Okay. If indeed she does get delirium, how should we be managing that?
First, you want to eliminate reversible causes if the person has a delirium. Are they oxygenating okay? So check an oxygen saturation. Are there electrolytes, within line if you've got IV fluids going on? Are they dehydrated, impacted? So look for reversible causes of delirium. And then you want to look at the medications. What medications are we giving them that might make this worse? We've already talked about the narcotics. We want to use the smallest dose as possible. Are they giving sleeping medications? Were they taking sleeping medications before they came into the hospital? We often don't think about the fact that maybe the person was taking a benzodiazepine at home on a regular basis, and now what we're seeing is withdrawal effects. Alcohol. A lot of older people don't admit to their regular alcohol intake. I have a drink every now and then. So, explore with the family.
Yeah, I think sleeping medications is sometimes an issue, and the family will bring it up as much as the patient, because they're concerned that they want the person to be able to sleep so that they heal quicker. In general, I usually say, sleeping medications are not a good thing. If the person does develop delirium, do you recommend Haldol, or what are your recommendations as a geriatrician?
Usually try to avoid, again, the benzodiazepines. They have the potential to make the behavior actually worse if they don't put the person to sleep. And the recommendation nowadays seems to be using neuroleptics, and the first line drug there generally is Haldol. Most people have experience with that. There are not a lot of adverse side effects with that in the acute setting, using it short term. You want to use, again, the lowest dose possible to try to control the behavior.
Yeah, sometimes what I've seen is nurses getting a physician order for Ativan. Now, my experience has been Ativan actually does the opposite of what it might do with a younger patient. For a younger patient, you would calm down and be less anxious and that sort of thing, but my experience has been older patients get more agitated, confused, and that sort of thing. I think another important piece is for you, Dr. Smith, to connect with the patient and the family prior to surgery and talk about this risk of delirium and be able to make some initial assessments of the patient prior to the surgery. What are your thoughts on that?
Yeah, I agree, Susan. I'd like to see them before she goes to surgery. It's really good for me to get a baseline of where this person is operating, so if we have trouble in the next day or two, I have a better idea of what their normal function is. It's really hard to come in and make an assessment of what a person's cognitive function is and what's the problem if I haven't seen them beforehand, because then I have to really rely on the family, which is why I was asking earlier, what's their experience. If they see the person is fine or normal, and now what's wrong with mom? What did you guys do to mom?
Yeah,
it's hard to know. So yeah, I'd love to go by and talk to her, and we'll bring up the issue of the possible delirium and why we're doing what we're doing, and we can maybe talk a little bit about the sleep medications and these type of things and why we would avoid those drugs.
Okay, that's great. And then the other issue that I wanted to talk about is this transition to home, because I think if potentially she does get some delirium, the family, they've been incredibly supportive in providing cares for the patient. They may need additional resources. So I was thinking we should be looking potentially for a referral to OT. or occupational therapist. Jessica, what are your thoughts? What could you potentially do for this patient?
And actually, as we're sitting here talking, it might not be a bad idea to do a cognitive screen before surgery. And then you could use that for your assessment too. We could use the Allen Cognitive Level Screen, which is just a 10-minute screen based on the Allen Cognitive Disability Theory that gives a pretty good general idea of how the patient is functioning. We could also do that post-surgery to see if anything has changed.
Oh, okay.
And to really see...
Is that the Allen lacing test?
Yep, the Allen lacing.
Okay. It's kind of a bedside tool.
Yep, the therapist would go in to the hospital or to the room and do it at bedside. It's 3 lacing stitches that go from easy to hard or more difficult. And then the scores are based on how much cueing they need to complete it.
It would be helpful to know, where is she functioning on a cognitive level, because that would be information that the therapist would make use of in trying to teach, or if they're becoming frustrated and things aren't going well, it would help them understand why.
And also for the family to let them know how much assistance and supervision she's going to need and continue to need even post-operatively into the next months and years.
Also, we've got a packet of information from the Alzheimer's Association, so I can connect with the family, see if they want any information on memory loss, and see whether or not they would like some resources through the Alzheimer's Association as well.